Good evening and namaste everyone. And happy Independence Day to everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this third series of Practice Pulse in Endocrinology. And today we are going to discuss about the very important topic, that is the endocrine hypertension. And to guide us, we are having with us Dr. Professor Subhankar Chaudhary, sir. He is a well-known endocrinologist from the city of Kolkata, and he is currently editor-in-chief in the Indian Journal of Endocrinology and Metabolism. So without wasting much time, I hand over the session to Dr. Chaudhary, sir. Over to you, sir.
Very good evening and warm greetings once more on the 74th year of our independence. While we all are hoping that 2021, next year, by next year this time, we will have freedom, at least from the significant menace of COVID-19 that we are under right now. But there would still be so many other menaces with us, one of which is hypertension. And we all know that hypertension affects anything between 25 to 30% of the adult population in possibly any country. And we also know that hypertension is the most important, the most common preventable risk factor for a whole host of conditions: cerebral strokes, heart failure, myocardial infarction, renal damage, and so on. While the treatment of hypertension, I think justifiably, is primarily done by family physician, the primary care physician. Then there are consultant physicians who are involved. Cardiologists are there. Nephrologists are considered. Neurologists are also there. Of course, endocrinologists are not generally thought of as people who would be involved with a lot of hypertension. But of course, we are not only in the field of diabetes, where rather than 25 to 30%, in diabetes, about possibly 60% or even higher number of people do have hypertension. So we are involved in management of hypertension. While hypertension largely or most commonly is idiopathic or essential, even this essential hypertension today we understand could also have some hormonal underpinnings. For example, when we talk of low renin hypertension in essential hypertension, there is a consideration, there is a suggestion that it would all be arising out of excess mineralocorticoid secretion, which is not overt. However, we have this evening two of the finest exponents in the field of endocrinology in our country, who will take us through and guide us on the important issue of hormones and hypertension. So first of all, we shall have none other than Professor Nihal Thomas, who is with the Department of Endocrinology at Christian Medical College, Vellore. He has more than 240 index publications. He has a great interest, not only is he a great clinician, he has also great interest in laboratory and basic science, and has done a whole lot of very important work, which is important not only for our country, even the importance goes out of our country. And his department has been recognized by BMJ and the Royal College of Physicians for excellence in teaching and training. He also happens to be Associate Director of the prestigious CMC Vellore. So over to you, Professor Nihal Thomas, and we shall have a sort of quick look at, I mean, these are vast subjects in their own merit, but a quick look as to when and how should we suspect a primary endocrine basis for hypertension. Over to you, Professor Thomas.
Thank you, Professor Subhankar Chaudhary, for that warm introduction. And it's wonderful to have Dr. Ganapathy with us as well. So I'm going to give an overview of endocrine hypertension over the next 20 minutes. It is one of the forms of secondary hypertension, meaning it is secondary to some other disorder, maybe renal, maybe endocrine, but this is endocrine hypertension that I'm going to be talking about. 1 to 5% of patients with hypertension have endocrine hypertension, and this may approach something like 7 to 15% in a tertiary care center. So it is reasonably common, and it should be looked for when we have people who have difficult to control blood pressure. When we talk about endocrine hypertension, we have certain disorders: primary hyperaldosteronism, pheochromocytoma, and Cushing syndrome. And the commonest of the three being that of hypokalemia due to primary hypoaldosteronism with alkalosis. There are other more exotic conditions like 11 beta hydroxylase deficiency and 17 alpha hydroxylase deficiency, which are rarer disorders when we come to the general physician. And there are endocrine disorders which are not so uncommon, which are accompanied by hypertension, but the primary problem of the endocrine disorder, like acromegaly, hypothyroidism, and hypothyroidism, may be dominant more than hypertension per se. One important disclosure that we as endocrinologists need to make, however, is that endocrine hypertension is not the commonest cause for secondary hypertension. It is, in fact, renal disorders like chronic renal failure, glomerulonephritis, renal disorder, damage due to vesicourethral reflux, and renal artery stenosis, which should be looked for first for secondary hypertension and then endocrine disorders. Well, at least in parallel. And we have another set of disorders which would be classified as miscellaneous, like coarctation of the aorta, patients with raised intracranial tension due to whatever cause, and of course, exotic causes like porphyria. So I just highlighted in orange as to what I would think would be the more common disorders in terms of frequency. And I will go through a few clinical problems to highlight some of these disorders. So here is a 28-year-old lady comes with severe acne, pigmentation, and proximal muscle weakness well till 2 months before. She has a serum potassium of 1.8 and metabolic alkalosis. So what are we dealing with? And since we tend to think in terms of multiple choice questions, here is a patient with hypokalemic alkalosis. What are the differential diagnoses? Diuretic usage, Bartter syndrome, Conn syndrome, Cushing syndrome. How would you like to identify? Now, this is the patient who's got a classical moon face, hirsutism, and a pigmentation, and has a blood pressure of 190 by 120 millimeters mercury. You go back to the differential diagnosis. Certainly, all these conditions can cause hypokalemic alkalosis. Having said that, Bartter syndrome is not associated with hypertension. Conn syndrome and Cushing's can be associated with hypertension. And of course, diuretics are used for treating hypertension. So you have ruled out Bartter's, and therefore your most likely diagnosis is iatrogenic Cushing syndrome because the patient has Cushingoid features. Think about Conn's as a possibility, but this is unlikely. And therefore, what would be the cause of this kind of patient with an endogenous Cushing syndrome, an ACTH producing hormone? Would it be pituitary? Would it be pancreatic? Or would it be a thiazide overdosage, which is unrelated to Cushing's? The patient had pigmentation, and therefore you think of ACTH excess, and therefore it has to be an endogenous Cushing syndrome, and the other causes are ruled out: pituitary microadenoma, pancreatic neuroendocrine tumor. And why does hypokalemia occur in these patients? It is due to a spillover, an excess of glucocorticoids, which spills over onto the mineralocorticoid receptor and causes hypertension. So this patient had a detailed workup. The MRI of the pituitary was normal, ruling out a pituitary microadenoma after an adequate biochemical workup. And we then did a Budota PET scan, which showed a pituitary tumor producing ACTH. This is an uncommon cause, but I'm just highlighting it as part of a differential diagnosis. Patient had an extensive surgery of the pancreas and then was treated. The metastasis was still producing hormones, and we give an enzyme blocker which attacks the enzymes in the adrenal gland. Ketoconazole is given, which therefore reduces the cortisol levels which are circulating. We have had extensive experience with ectopic Cushing syndrome, and you can actually differentiate these depending on the hormonal evaluation. Ectopic Cushing's have much higher ACTH levels, much higher urine-free cortisol levels compared to the pituitary microadenomas. An 18-year-old lady presented with severe hypertension for 3 months. urine metanephrines were 100 micrograms in 24 hours, and urinary normetanephrines were 5,700, much more than the cutoff of 600 micrograms in 24 hours. And this is, so then we have zoned in on this patient. We have done a biochemical workup, and we find that there's a large tumor on imaging. The optimal test for imaging of the abdomen is a CT scan. We don't need to do an MRI in most situations for secondary hypertension. So we do a CT scan after getting the biochemical localization, and we find that there's a large right-sided tumor over here, which is enhancing on contrast, which means it's very vascular. So this is a pheochromocytoma. The patient also at the same time seems to have vascular lesion in the tail of the pancreas. And therefore, there is some other tumor in the pancreas which is coinciding with the potential pheochromocytoma. So basically, this is what she has. And this is what an isotope scan to look for other tumors has also been done. We find a one-sided tumor over here, which is large, and a smaller tumor on the left side. So you underwent a right adrenalectomy. Now, when you operate on these patients, you need to basically try, if possible, when you're taking out both tumors on both sides of the adrenal, you'd like to preserve the glucocorticoid function. So this is a cortical sparing left adrenalectomy and a total adrenalectomy on the right side. And also the tumor in the pancreas has also been removed over here. For this patient, as you can see, the large tumor under the liver, this is a right adrenal tumor. And essentially the histopathology shows what is classical of a pheochromocytoma, a highly mitotic tumor with nuclear polymorphism. Now, nuclear polymorphism in other patients would make you think of malignancy. But these mitotic tumors in endocrine disorders, in pheochromocytomas, do not indicate a malignancy. So you cannot make a diagnosis of a malignant pheo just from the histopath per se. You need to have vascular and capsular invasion or metastasis.
Professor Thomas's voice is trailing.
Nihal, we are not able to hear.
So this patient had adrenal tumors and pancreatic tumors. And this is what you think about a possibility of von Hippel-Lindau syndrome, which is a condition which has adrenal tumors, with pheochromocytomas, pancreatic lesions, as well as occasionally renal carcinomas. Okay, so pheochromocytomas have been looked at our center, and this was the first publication done by my teacher and his colleagues from endocrine surgery, and have looked at this almost 25 years ago. And more recently, my colleague Simon had actually highlighted the fact that with this, there are a number of endocrine tumors, pheochromocytomas, which have hormonal associated inherited conditions. And this has to be looked at. So when you have a pheo, you need to do a good pedigree chart, and then you need to look for these syndromes. Multiple endocrine neoplasia type 2, which is A and B. A has parathyroid adenomas, B have marfanoid habitus and mucocutaneous neuronomas. Von Hippel-Lindau syndrome, as I mentioned, as in this patient, and then you have the succinyl dehydrogenase deficiency syndromes, the B, which are frequently malignant and frequently of maternal or paternal inheritance, the D, which are associated with carotid body tumors in addition. So 35-year-old female presented with diabetes, hypertension, and progressive weight loss, severe hypertension, as you can see over here, urine normetanephrines once again elevated, and you can see over here, the patient has a large retroperitoneal tumor, extraadrenal lesion, which is producing these hormones, and severe hypertension. Incidentally, the CT scan also showed a cut which showed a lytic lesion in the pelvis. So this patient has a metastatic lesion going to the pelvis in addition. And we did an isotope scan. It showed more than the X-rays. Then the CT scan, it showed metastatic multiple lesions over here. So retroperitoneal tumor. And here, how do we treat this patient? It's malignant, it's metastatic. What are the options? So instead of we try to remove the extraadrenal tumor, but in addition, we give isotope therapy for these patients, and she underwent palliative chemotherapy subsequently. So this very malignant pheochromocytoma or paraganglioma rather is that of an STHB mutation and genetic condition. And we do these tests in our lab because it helps in predicting tumors in other family members in addition. This is another publication which has looked at the multiple endocrine neoplasia in our population, besides STH mutations, and this is very similar to the Western data showing that certain germline activating point mutations are responsible for multiple endocrine neoplasia, which can cause medullary thyroid cancer and pheochromocytomas at the same time, along with parathyroid adenomas in MEN1. So when you have a patient, when you think of a pheochromocytoma, there are several differential diagnoses which are definitely more common than a pheo. As a physician, if you have someone who comes with you with palpitations, a slight rise in blood pressure, sweating, tremors, anxiety, and panic attacks are certainly very common. Paroxysmal atrial tachycardia can also mimic this. Menopausal symptoms in certain women, you can have extremely severe menopausal symptoms with fluctuating blood pressure and hot flushes. Vasodilating headache, migraines can also have borderline high blood pressures with headache. You shouldn't be thinking of fears in all those situations. And of course, hypoglycemia, wherein hypoglycemia stimulates catecholamine release and can also cause a mimic of a pheochromocytoma. And of course, this is common in patients with diabetes. So how do we manage our fears? We first check the urinary metanephrines, then we do imaging of the abdomen and adrenals, and then we may need to do an isotope scan to see if there are more tumors in certain syndromic conditions where you have bilateral or multiple lesions. Preoperatively, this is the only cause for hypertension wherein you load the patient with salt because you do not want to have a collapse in blood pressure after surgery. And you alpha block them for 10 to 14 days. You can give phenoxybenzamine, which is an ideal drug, but then cheaper and more easily available is prazosin. You alpha block them. And then towards the end, you add a small dose of beta blockade in 10 to 14 days time. And if it's large and it's abutting the spleen, you may need to give them a pneumovax in case you're anticipating a splenectomy. Surgery is given under general anesthesia, which uses gases like isoflurane and enflurane. Of course, now these are the common gases used, and they are less catecholamine stimulating at the time of surgery, therefore not provoking rises in blood pressure. Laparoscopic surgery is often required if they are is generally done in most patients with pheos nowadays. Even large tumors about 8 to 10 centimeters are taken off with laparoscopy. But if it's multiple across the peritoneum, you may need to do an open surgery. Here is another patient, a 25-year-old that had a bleed, right hemiparesis, and then she got married, conceived, had a baby born by LSCS, and then she complained of headaches and profuse sweating and worsening of symptoms while using the toilet. Typical micturition syncope. Her blood pressure was elevated mildly, and she had hypertensive changes in the fundus. Ultrasound, abdomen, and renal artery Doppler were normal, and she had elevated norepinephrine levels. And so here, as you can see, the MRI shows this large tumor inside the bladder. It's a bladder paraganglioma. And an MIBG scan, then after 7 days, you wait for the washout of the isotope, and still there's an uptake in the bladder, shows a bladder pheochromocytoma. So she underwent a partial cystectomy, and to this day, she's normal. She's doing extremely well, and her metanephrines and norepinephrines are normal. And this is the tumor, spindle-shaped tumor inside, which was picked up from inside the bladder. And the chromaffin staining, an isotope, an immunostain for neuroendocrine tumors is strongly positive in this patient. And these are the tools which we use to pick up neuroendocrine tumors by using synaptophysin, chromaffin, which are specific for neuroendocrine tumors. This is our experience with bladder fears, and by and large, interestingly, the micturition syncope was a less common symptom. Some of these tumors might recur, and you need extensive surgery in these patients. That's in a small proportion, about 10%, in spite of good surgical procedures, maybe due to adherent small bits in the peritoneum, or due to a recurrent tumor, as in a malignancy, which I told you is sometimes difficult to make a diagnosis of. Okay. Now I talked about Conn syndrome or hypoaldosteronism, which is the most common cause of endocrine hypertension. It can be due to a tumor or it can be idiopathic, wherein there is no obvious increase in size of the adrenal glands or tumor. And this can be quite common. If you have a refractory hypertension in clinical practice, always think about doing a renin aldosterone level if they are hypokalemic. And even if they have a borderline low potassium, you should think of an hypoaldosteronism as a potential cause. They are much more common in the population, and maybe as high as 5 to 10% of the general population may have some degree of hypoaldosteronism when you think about hypertension. So essentially, the physiology over here, high aldosterone perpetuating potassium excretion and sodium reabsorption. And they don't have much hypernatremia in spite of the aldosterone effect because of what you remember, the aldosterone escape phenomena, because the atrial natriuretic peptide is stimulated and they have an natriuresis. So the sodiums are normal or even just borderline high, but never really hypernatremic. But they have hypokalemia and alkalosis. So this is a lady who came with flaccid quadriparesis, hypertensive, had borderline blood pressure. This was many years ago, and she had been put on centrally acting drugs, which we seldom use nowadays, and atenolol. She had evidence of hypertensive changes, and it's important in all these patients to look at the fundus and auscultate the heart to look for features of left ventricular hypertrophy and end organ damage. She had proximal myopathy, and this is a feature of hypokalemia which is prominent. And as you can see here, hypokalemic alkalosis, U waves on the ECG in addition. And she had an adrenal tumor. You can see the dark lesion, which is totally in contrast to a patient who has fever, which is very vascular. These patients are fat laden, tumors are fat laden, and therefore are much darker on appearance in 80% of cases. It's a cortical adenoma. So these patients, when you make a diagnosis, you check a renin and aldosterone level. They often missed in mild disease. Periodic paralysis is more common when you have adrenal adenomas, particularly 50% of adrenal adenomas with hypokalemic alkalosis have recurrent muscle weakness, which may occur. And this is a differential diagnosis for periodic paralysis as Conn syndrome and renal tubular acidosis, other common causes. And this is one which should be thought about. Easy to remove with a laparoscopic surgery. The preoperative treatment, or those in mild disease with mild hypertension, you can use spironolactone, ACE inhibitors, and of course even calcium channel blockers are very effective over here. The posterior approach which is used in these patients with a laparoscopic technique. And here is a classical Conn's adenoma, which is yellowish, a fat-laden tumor, as I mentioned to you. And this typical appearance, because the fat gets washed out from the H&E stain, you can just see these clear cell tumor which occurs in these patients. So let me just summarize. When does one investigate for secondary hypertension? Difficult to control with maximal doses of 3 drugs, early age of presentation less than 30 years, atypical symptoms and signs with recurrent palpitations, marked weight loss as in FEOs or in patients with ectopic ACTH producing Cushing's, where they actually lose weight because they're very catabolic. Muscle weakness, polyuria and recurrent urinary tract infections in patients with polyuria due to hypokalemia, which is chronic. Recurrent UTIs in patients with vesicular reflux. Fever, arthritis, and hematuria in patients who have a vasculitis. So therefore, I'm covering all causes of secondary hypertension in this symptomatic screening process. Cutaneous lesions in polyarteritis nodosa and in SLE. Family history of severe hypertension and renal failure in patients with polycystic kidney disease in adults. And of course, familial hypertension in patients with FEOs due to von Lippel-Lindau syndrome, multiple endocrine neoplasia, and succinyl dehydrogenase deficiency. And severe presentations with encephalopathy, papilledema, and left ventricular failure should be screened for all common causes of secondary hypertension without disregarding the age. Even if they're older people, you should look for a secondary cause in these patients. The examination checklist, Cushingoid features, acromegalich features. Severe hypertension, you have retinopathy, which may be severe, and the features of MEN2, the mucocutaneous lesions on the lips and the tongue, and features of Turner syndrome when you have coarctation of the aorta. These are the baseline investigations which you can do in your clinic as a primary care physician. Basic tests which should be done in all patients with young onset hypertension, or what you think of symptoms of secondary hypertension. And of course, the catecholamines which have replaced the vanillin acid. It's the urinary metanephrines. Plasma assessment of catecholamines is ideal, but it needs the LCMS, and therefore the cost may be about 7 times more in our country, and therefore we're using it much less in our country. Therefore, isotope scans, MIBG, DOTA-PET, aldosterone and renin levels, which should be done in patients with secondary hypertension when there's no other identifiable cause, because it's common. CT abdomen is far more productive and cheaper than an MRI, and DSA, of course, in patients who have other causes like polyarteritis nodosa, etc., and a vasculitic workup. So I'd like to thank a number of my colleagues for the platform that we have built for investigation of secondary hypertension, my endocrine colleagues, surgical endocrinology, and nuclear medicine. In addition, thank you very much for your patient listening.
Thank you very much, Professor Thomas, with your vast experience, especially working at CMC Vellore. We have had a glimpse of fairly rare causes as well, and relatively common causes of endocrine causes of hypertension. And you have also very nicely covered when one should suspect an endocrine cause, or for, on a broader perspective, secondary cause for hypertension, and what would be the easy things to do. And of course, eventually one could, of course, refer the patients to an endocrinologist. So what we plan to do in the next part is to have Professor Ganpati Bantwal, who heads the Department of Endocrinology at the St. John's Medical College in Bangalore. He's a principal investigator in several clinical trials. He's got numerous papers in peer-reviewed international and national journals. And for us also, it's a very sort of coveted post that he is now the president-elect for the Endocrine Society of India. So what we would hope, of course, Professor Thomas has already taken us through several case scenarios, but we'll have Professor Bantwal maybe show us whether or what's the result of treating various endocrine causes of hypertension, whether the hypertension reverses or what happens, the natural cause of the disease. In his own way, I'm sure he will take us through the story of endocrine hypertension with real life case discussion. Over to you, Professor Bantwal.
I hope, thank you, sir. Thank you for that kind introduction. My job actually has been made easy by Professor Nihal. I'll be talking about 2 case scenarios. The same thing what Nihal presented, but a little bit more in detail. So let me begin with the case. 23-year-old lady, 20 weeks of gestation, had history of labile hypertension since 12 weeks of gestation. She had episodes of headaches, sweating, palpitations. She was on methyl dopa since 12 weeks of gestation. In the previous pregnancy, she had an abortion at 4 months. And during this pregnancy, her blood pressure was 200 by 120, significant partial drop, 70 systolic and diastolic of 20. Fundus revealed grade 3 hypertensive retinopathy changes. All peripheral pulses were very well felt. There was no difference in the blood pressure between upper and lower limb. No renal bruit was appreciated. She had no pedal edema. There were no cutaneous markers suggestive of Men's syndrome. So what's your diagnosis? Pheochromocytoma. So on evaluation, ECG echocardiography revealed evidence of LVH, no features of coarctation. There was no albuminuria, normal liver function test, renal function test and coagulation profile were normal. Obstetric ultrasound revealed a single live intrauterine fetus of 21 weeks gestation. Abdominal ultrasound revealed a suprarenal mass with internal vascularity measuring 6 into 4 centimeters. The kidneys were normal. And since she was pregnant, we got an MRI, which showed an adrenal mass 6.5 into 4.6 into 0.8 centimeter, which was isointense. T2 hyperintense in the left suprarenal region. The left adrenal gland was not visualized properly. So the diagnosis was looking like a pheochromocytoma. So we treated her with prazosin and nifedipine followed by labetalol and oral salts of 2 grams twice daily. Her blood pressure reduced with further titration in the doses of the antihypertensive. This patient underwent adrenalectomy at 24 weeks gestation after achieving adequate alpha blockade and optimal BP was achieved. Now, if you see here, labetalol has both alpha and beta blockade, but for practical consideration, you should take it as a beta blocker alone because it has a ratio of 1:7. So predominantly, it has a beta blocking effect. So if you use it first, it actually can produce unopposed alpha blockade, alpha activation, and hence what happens is you may have hypertensive crisis can happen. So hence labetalol, although it has a combination, always think it's acting like a beta blocker. Perioperative intra-op, there was evidence of tumor thrombus into the renal vein, which was resected en masse. She had no hypertensive crisis. So biopsy revealed a pheochromocytoma with vascular invasion with a PAS score of 1/20, which is benign. Anything more than 4 is considered as malignant, suspicious for malignancy, with a Ki67 index less than 1%. So this is a PAS score, that is pheochromocytoma of the adrenal scale score. So if you have a large nest, we give 2 points. Central or confluent tumor necrosis, 2 points. High cellularity, 2 points. So like that. So then we look into the mitotic figures. If it is more than 3 per high power field, we give 2 points. Atypical, 2 points. Capsular vascular invasion, 1 point. Extension adipose tissue. So totally you have 20 points. And if the score is more than 4, suspicious for malignancy. In the post-op period, there was persistent hypertension requiring antihypertensive, but then her BP was well controlled with alpha the calcium channel blockers, alpha and beta blockers. Her fetal heart rate was normal throughout the post-operative period. So now coming to what changes happens during pregnancy. Normally in pregnancy, there is a fall in the blood pressure towards the end of the first trimester, reaching a nadir between 22 to 24 weeks. We say hypertension during pregnancy when the systolic is more than 140 and the diastolic more than 90. And hypertension complicates pregnancy in approximately 15% of pregnancies. So this hypertension is a leading cause of maternal and perinatal mortality and morbidity. There is increased vascular distensibility, reduced peripheral vascular resistance accompanied by the physiological changes including sodium retention, increased extracellular fluid, and upregulation of the RAS. Pheochromocytomas in pregnancy, approximately 100 cases have been reported. The clinical presentation is very similar to acute toxemia of pregnancy, but the differentiating features include absence of proteinuria and edema, presence of partial hypertension, labile or paroxysmal hypertension, or hypertension occurring in the first trimester. What do catecholamines do during pregnancy? In healthy pregnant women, plasma and urinary catecholamines levels are not or only slightly increased. Even in preeclampsia, plasma catecholamines are only slightly elevated because the catecholamines hardly cross the placental barrier. And in patients with PHEO, the umbilical cord contains less than 10% of the maternal concentration, catecholamine concentration. Noradrenaline transporters are expressed in the placental cells, which enable the intracellular uptake of catecholamines. And placental cells also contain catecholamine metabolizing enzymes like monoamine oxidase and catechol-O-methyl transferase, serving as a protective barrier for the fetus against excessive catecholamine exposure. Now, coming to the fetus, they have a high basal catecholamine secretion rate, but the circulating concentration are low because of high clearance. So this is required because of its stress in the mother. Fewer in pregnancy, even transient increase in the maternal levels of catecholamines have a deleterious effect on the uteroplacental circulation. So which can lead to extreme vasoconstricting, leading to intrauterine hypoxia and placental abrasion, which can have a serious risk to the fetus. So how do you diagnose during pregnancy? So our patient was on methyl dopa, so you had to stop this drug at least for 2 weeks. And then the same thing, 24-hour urine metanephrines or non-metanephrines you can do. Best investigation for localization of tumor in pregnancy is MRI. How do you manage during pregnancy? First alpha blockade followed by beta blockade. The alpha blockade of choice is phenoxybenzamine, but then as Dr. Nihal told, it's more expensive. You could use prazosin. Hypertensive crisis sometimes can happen if you don't control it, leading in fetal demise due to uteroplacental insufficiency. And if you have a hypertensive crisis, you have to manage with IV phentolamine or sodium nitroprusside. So what are the targets? So in non-pregnant women, patients with PO, we aim less than 140/90. But here they say it's better we target around 130/80 because they claim less hemodynamic stability with a higher blood pressure levels. Best time to do excision of the tumor is in the second trimester. If pheochromocytoma is diagnosed after the second trimester, adequate alpha blockade should be achieved and BP controlled, and pregnancy should be continued till term when you do a combined cesarean section and removal of the tumor at term. In fact, if you allow LSCS, the mortality is more, which is around 30% compared to LSCS where it is less than 10%. 50% can have sometimes persistence of hypertension despite the removal of the source of excess catecholamine production. The tumor recurrence rate is around 14% in adrenal disease and 30% in extraadrenal disease. And last but not the least, because this patient is young, do a genetic screening for hereditary FEO because 1/3 will have an hereditary predisposition. So I will do a next case. Mrs. RB, 35 years age, hypertension since the age of 35, always uncontrolled hypertension on regular medication. She was on calcium channel blockers and ARBs, regular cycles. There were no history of FEOS. There was no history suggestive of acral enlargement, headache, or visual symptoms. No weight gain, striae, rounding of the face, ink circumference, proximal myopathy, or virilizing features. No history suggestive of muscular weakness, no stones or fractures to rule out parathyroid, hyperpara. No neck swelling, no history of young onset hypertension or IC bleed. Evaluated by a primary physician found to have persistent hypokalemia. CECD abdomen was done, it showed a left adrenal adenoma. It was referred to our institute for further evaluation. When do you suspect case dissection for PA? So if you have a sustained hypertension, more than 150 systolic or 100 diastolic, more than 140/90 resistant to 3 conventional antihypertensive, including a diuretic. If the patient requires 4 or more antihypertensive drug to have a blood pressure control, hypertension or spontaneous or diuretic-induced hypokalemia, hypertension and adrenal incidentuloma, hypertension and OSA, hypertension and a family history of early onset hypertension or cerebrovascular accident at a young age, less than 40. Also recommend case detection for all hypertensive first-degree relatives of patients with PA. So normally we do a PSC PRA. How do you collect it? Collect it mid-morning at around 10 a.m. after the patient has been sitting, standing, or walking for at least 2 hours and seated for 5 to 15 minutes. Collect the blood carefully, avoid stasis and hemolysis. Maintain the sample at room temperature and not on ice, as this will promote conversion of inactive to active renin during delivery to lab. And then you should see that there is a rapid freezing of plasma component pending assay. If the patient has hypokalemia, always ensure that you correct the hypokalemia because hypokalemia reduces the aldosterone and then you may get a falsely negative the ratio, aldosterone, PSA-PRA ratio. Also, false negative ratios can happen when the renin is stimulated by dietary salt restriction, because the moment you find somebody has hypertension, we tell salt restriction, and you can get a falsely negative ARR. Concomitant malignant or renovascular hypertension, pregnancy. In fact, you can get a false because you have a high level of progesterone. Progesterone has an anti-mineralocorticoid effect, so that's another reason. But the same process is for diagnosing in pregnancy. Only if you do a direct renin measurement, you may get false negative. So treatment with diuretics, including spironolactone, CCBs, ACE or ARBs, you have to be cautious. If you get a low PRA, that means to say you are fine. Especially spironolactone, which can increase the PRA. So if you find in a patient on spironolactone, if the PRA is suppressed or if the patient continues to have hypokalemia, which means to say the blockade is not complete, and then the PSA-PRA ratio is still valid in these patients. So at our hospital, pulse rate was 88, blood pressure 170/90, on amlodipine 10 milligram and telmisartan 40 milligram. There was no postural variation. No pallor, icterus, cyanosis, normal JVP, thyroid and spine were normal. No stigmata of Cushing's, acromegaly, or other syndromes. No renal artery bruit. Cardiovascular system was normal. No added sound. CNS was normal. Sodium was 141. Potassium was 3.1. Creatinine was normal. We corrected orally the potassium with the pot chlor syrup. PSA-PRA was done after the correction, and for the hypertension, we uptitrated the CCB. Echo showed concentric LVH, fundoscopy revealed grade 1 hypertensive retinopathy. We also did an overnight dexamethasone suppression test, though this showed hypertension, hypokalemia. There were no stigmata of Cushing's. The size of the tumor was a little bit big, so that made us suspect that we should also do a cortisol level, because it has been found if the size of the tumor is more than 2.4 centimeters, you can have co-secretion of cortisol, and then post-op, suddenly you may find patient may have hypertension, which is because of suppression of the adrenal glands. The cortisol secretion may take some time to recover. So that's the reason whenever you find a tumor size more than 2.4, always look for even cortisol hypersecretion. His PSC was high, the PRA was 0.8. In fact, the ratio was more than 50. In fact, urinary VMAs and metanephrines were also then, and they were normal. So PSA-PRA ratio was more than 50. So what about confirmatory test? Has it to be done in all patients? So what the confirmatory test, so what we are doing, PSA-PRA ratio is actually a screening test. Anything more than 20 is suspicious. That means you have to screen. For confirmation, you require to do actually a oral sodium loading test. So they require to increase their sodium intake to more than 200 millimoles for 3 days. So verified by a 24-hour urine sodium content, which should be more than 200 millimoles for 24 hours. So patients should also receive adequate release of potassium chloride supplementations so that the potassium is maintained normal. And then the urinary aldosterone is measured in the 24-hour urine collection from morning of day 3 to morning of day 4. So aldosteronism is unlikely if the aldosterone levels, urine aldosterone levels are less than 10 microgram per 24 hours in the absence of renal disease. And if you have level more than 12, it is suspicious or it is highly likely. So you can also do a saline infusion test, 0.9% saline IV over 4 hours, 2 liters are given, starting at 8 to 9:30 a.m. So measure the blood samples for renin, aldosterone, cortisol, and plasma potassium at time 0 and after 4 hours with BP and heart rate monitored throughout the test. And if you find that the post-infusion plasma aldosterone level less than 5 nanogram per deciliter, it makes the diagnosis unlikely. More than 10 is highly probable. Values between 5 to 10 are indeterminate, especially a cutoff more than 6.8. If you have more than that, we say it's more likely to have PA. The other test is the fluorocortisone suppression test, and the captopril suppression test, a challenge test can be done. So confirmatory test is not required if the patient has spontaneous hypokalemia, plasma renin below detection level, and the PSC is more than 20 nanogram per deciliter, plasma aldosterone concentration. So our patient had this, so we did not do the confirmatory test. Next, we have to do what is known as a subtype testing. So you have to do an adrenal dedicated abdominal CT, one to exclude large masses. Maybe we could be having adrenocortical carcinoma. And it also guides the therapeutic approach by distinguishing between aldosterone producing adenoma or a primary adrenal hyperplasia from glucocorticoid remediable hyperaldosteronism or idiopathic hyperplasia. So when a solitary hyperdense unilateral macroadenoma more than 1 and less than 2 centimeters and normal contralateral adrenal morphology are seen on CT in a young patient less than 35 with severe PA, primary aldosteronism, unilateral laparoscopic adrenalectomy is a reasonable treatment. If you have IHA or GRA, it should be treated medically. If the patient says, if the patient has aldosterone producing adenoma, he says, no, I don't want surgery, I want to treat medically. Yes, you could treat the patient medically, but ensure that you give an aldosterone receptor blocker, that is spironolactone. And if he is a male, if he has side effects of that, you could actually give him eplerenone, which does not have the anti-androgenic side effects. So you may get the blood pressure controlled with other antihypertensives like say CCBs, etc. But then you have to give an aldosterone blockade is necessary to reduce the morbidity and the mortality associated with the excess aldosterone level. So CECT abdomen was done. It showed a tumor, as I told you, with a delayed washout. 24 into 18 millimeter left adrenal lesion, hypertense. The baseline HU was 10 to 15. So the final diagnosis was left adrenal adenoma, primary aldosterone syndrome. Pre-op, both hypertension and hypokalemia should be well controlled before the patients undergo surgery. And if you don't control it, it's better to delay the surgery. You could probably add an mineralocorticoid receptor antagonist like spironolactone. So what did we do? Started on ARBs, added spironolactone 25 milligram, continued on amlodipine 10 milligram twice daily, BP stabilized, potassium was normalized. Underwent left adrenalectomy with coverage of hydrocortisone in view of anticipated contralateral adrenal suppression. Post-op day 1, BP was 127, potassium improved to 3.1. In fact, he was off all antihypertensive, required antihypertensives till post-operative day 3. After that, he required BP was well controlled with 5 milligram amlodipine and potassium was normalized, discharge on 5 milligram amlodipine. After 2 weeks was off the drug, blood pressure normalized and potassium was also normal. So his HPE showed a dark, nodular dark brown tissue, 1.8 into 2 into 0.8, 11 gram. Cut sections discussed showed a circumscribed yellow lesion. Dr. Nihal had highlighted that. Microscopy showed circumscribed neoplasm, cells with clear to foamy cytoplasm surrounded by thin walled sinusoids. Mild nuclear neoplasm seen, no significant mitosis or necrosis. Post-op, what do? Measure plasma aldosterone and renin activity level shortly after surgery as an indication of early indication of biochemical response. Withdraw potassium supplementation on post-op day 1. Discontinue spironolactone, reduce antihypertensive therapy appropriate. Post-op IV fluid, give them normal saline without potassium chloride supplementation unless potassium is less than 3. Check potassium once weekly every 4 weeks. 5% can develop clinically important hyperkalemia because you have a state of hypoaldosteronism temporarily till the other side recovers. Encourage generous sodium intake to reduce the hyperkalemia. If the serum potassium rises more than 5.2, you could treat temporarily with fluorocortisone. Monitor potassium weekly. Cut fluorocortisone to half if the potassium is less than 4.5. And the typical duration is around 2 weeks. Some may take a longer time. BP typically normalizes or shows maximum improvement in 1 to 6 months after unilateral adrenalectomy, but can continue to fall for up to 1 year in some patients. Some perform post-operative fluorocortisone suppression tests performed at 3 months and after surgery to assess whether the PA has been cured from biochemical perspective. Sometimes patient can have persistent hypertension, probably because of coexistent primary hypertension and older age or long duration of hypertension. Factors associated with hypertension resolution include having one or no first degree relatives with hypertension and pre-op use of two or lesser antihypertensive drugs, higher PSA-PRA ratio pre-op, higher urinary aldosterone secretion or positive pre-op response to spironolactone. So this is how the treatment of primary aldosteronism is. If you have aldosterone producing adenoma or primary adrenal hyperplasia, laparoscopic adrenalectomy is treatment of choice. If the patient refuses, you can give a mineralocorticoid receptor antagonist, which could be non-selective like spironolactone or selective like eplerenone. If the patient has idiopathic hyperplasia, you could treat with a mineralocorticoid receptor antagonist. If the patient has severe primary aldosterone markedly asymmetric on AVS, you could consider unilateral surgical debulking. The correct dose of spironolactone or eplerenone is whatever it takes for a high normal serum potassium without the aid of potassium supplementation. And for control of blood pressure, you could add other drugs like CCBs, ACRBs, or a diuretic. When you do genetic testing, if you have an onset of PA less than 20 years of age, and in those with a family history of PA or strokes at a young age, do a genetic testing for familial hyperaldosteronism type 1 GRA, or you can do for type 2 and type 3 also, especially for the KCNJ5 mutations. Coming back to our case, we followed the patient up after 6 months. Blood pressure was 124/80. The patient was off all antihypertension. Thank you for patient hearing.
Thank you. Thank you, Professor Ganpati Bankwal, for an excellent presentation taking us through two important cases. We have a few questions already. So first of all, can we have Dr. Nihal Thomas? This is Dr. Siddhant. His question, which you have just alluded to, is what would you prefer, plasma versus urinary metanephrines?
Yeah, thank you for that question, Dr. Siddhanta. In fact, it is very relevant. In terms of sensitivity and specificity, you may have an advantage of about 10 to 15% if you're using plasma versus urinary metanephrines. So it definitely would be more accurate to use plasma metanephrines. The specificity may in fact go down when you're using urinary metanephrines, which is what we are using at this point of time. Having said that, the cost of plasma metanephrines goes up significantly because you're going to use a LCMS. And setting up an LCMS for any test needs the number of tests to be done in bulk, in large volume. It needs special expertise, and it is significantly more costly. So as I mentioned, we were planning to do it in our own lab in biochemistry in CMC Velo, but found that the actual cost would go up by around 6 to 7 times. So eventually, I think it will come into being, but give it more time, and it would be there.
Another question, maybe Dr. Nihal Thomas still, Dr. Ozar. So his question is not related specifically to endocrinologists, but overall, it's very important. Would you rely on the accuracy of the digital blood pressure instruments?
Yeah, so digital blood pressure measurements for monitoring of blood pressure, particularly if you want to do it on a routine basis for monitoring these patients at home, are useful, particularly for patient care. And I think as we use glucometers for measuring glucose levels in patients who have diabetes, these devices are useful for home monitoring. They set about a certain standard in terms of patient care. It gives patients responsibility about their own disorder that they have, and they can keep an eye. So in terms of primary care and secondary care of control of blood pressure, these play a very important role. Having said that, these machines need to be checked periodically. I would recommend that at least once in 2 months that these machines are checked and standardized against a gold standard with a device in a hospital to ensure that there's accuracy when utilizing these devices. So certainly they do have a role.
And I also feel that it's very important to stick to the proper guideline, proper usage, where exactly the what do you call it, the manometer should be placed medially, laterally. That should be specifically demonstrated to the patient. And even in my own use, I have seen the blood pressure values can fluctuate significantly between two measurements if the exact method is not followed. So that's important. But increasingly, I think people are encouraging more and more home monitored blood pressure readings and relying more upon that. And in my personal experience, at least, I feel that I see many patients in whom the blood pressure recording is high, and the patient says, "No, doctor, I have done it at home. It's always normal." And in several instances, I have found that after several checks, that is correct. I mean, so getting the real blood pressure possibly is better done at the patient's own residence, if of course the methods properly followed. Dr. Banthwal, do you want to add to this?
Yes, sir. I do agree with both of you, especially after the sprint trial. In fact, where they use this type of BP apparatus, I think it's more and more people. I mean, even I feel confident actually to tell the patients to use that for monitoring the blood pressure. Previously, I used to have a feeling that no, you get false reading in that. But then sometimes what happens, the first reading may be abnormal. Maybe you could repeat it after a minute or two. The second reading is actually more reliable because first reading may be haywire and the next reading you find it's normal. And if you do the third reading, it's also once again, it'll fit with the second reading. So that's another thing which we should, I think, keep it in mind when you are getting a high values and or a very low value also.
Sure. And in the COVID era, possibly we want less interaction, physical interaction with their patients, and we would be encouraging, at least in these times, that patients have their blood pressures recorded at home rather than getting pressure recorded in the clinic. So one for Professor Bantwal. This is Dr. Shah. So this is a young lady who is on oral contraceptive pill and is found hypertensive. So what do we do? How do we evaluate? Yeah, provide any further history, family history, whatever we don't have right now.
Well, in that case, if we feel that because the patients on oral contraceptives, it's better to stop the medication for around 8 weeks and then reevaluate. Suppose we are suspecting Cushing's, for example, and patient is having, and not much stigmata. Suppose for PIA, if you want to check for aldosterone, you could stop it because this patient is actually, you could stop this drug, wait for around 6 weeks or 8 weeks and retest it. As I told you, in pregnancy also for primary hyperaldosteronism, the same criteria exist. If you find that if the plasma renin activity is suppressed and the aldosterone levels are high, which indirectly says the patient has primary hyperaldosteronism itself. And also you don't require what you call confirmatory test if you find the plasma aldosterone concentration is more than 30 nanograms per deciliter. The interference happens only when you're doing a direct renin measurement. So then actually the interference happens. Otherwise, you could use the same criteria for making a diagnosis of PA if the patient is on OCPs also. But in OCPs, we have the liberty of, we could stop it and recheck it after some time. Pregnancy is more difficult. And a little bit about pregnancy is, we say progesterone has anti-mineralocorticoid activity, and we are saying we are diagnosing PA during pregnancy. That's because some of them could have mutations in the H receptor, and that can stimulate this production. And similarly, beta-catenin receptor mutations, and also I think HCG mutations. So if they have these mutations, they are the ones who develop hypertension during pregnancy, though pregnancy is a state of progesterone has an anti-mineralocorticoid effect.
Right. So what about OCP, estrogen itself, causing hypertension?
Yes, that's a reason better to stop it. Yes, it can produce because renin, increased renin,
But my personal take is the standard low estrogen dose OCPs that are more commonly used these days possibly do not cause hypertension. Is my personal belief. I mean, if you stop, usually the hypertension does not go away. So, what would be Dr. Nihal's take on it?
Dr. Shubhankar, can I repeat that question? It's not
Yeah,
clear.
okay. This was about. Sorry, maybe I'm not being audible well. This is about a young female with hypertension who is on OCP. So, what would be the contribution of the OCP to the cause of hypertension?
So very often, these women may be individuals also who have polycystic ovarian syndrome, and one might in fact expect hypertension to be more common in these individuals who are either physically unfit or also have obesity in addition. Having said that, I do believe that a proportion of around at least 20% may have the OCPs per se contributing to blood pressure, but it's generally not that severe in my experience. I think it's generally more mild to moderate diastolics up to around 100 or a little bit more than that, generally not that severe. So that's how it is. And most of the other indices, the biochemical indices, are eventually quite normal in this situation.
Right. We, there's another question from Dr. Atul. So, is there any relation of the menstrual phase while measuring plasma aldosterone? Does it matter, Dr. Nihal?
I'm sorry.
Menstrual phase, menstrual phase and measurement of
Yeah.
plasma
No,
aldosterone.
I don't think we need to fine tune things to that extent. Uh, there are a lot of practicalities when we look at patients and measuring hormones in these situations. So I don't think there's going to be any major fluctuations or changes. There are some peaks that you might expect, but I mean, to actually make things convenient for the patient in terms of patient care, this is not at all required. If you have florid hypoaldosteronism, it's generally going to be the case. Borderline cases are generally not going to be having, different major differences in aldosterone levels.
Dr. Bantwal, you mentioned about this Con syndrome. So now it's medical treatment for cons in pregnancy. Can you use spironolactone or eplerenone?
Okay, see, theoretically, spironolactone is actually a category 3 drug, or you can say category X also, because especially if there is a male fetus, then you can have some problems with that. But then this happens in the first trimester when actually the organogenesis happens. But the preferred drug is actually eplerenone because it does not have that effect. It's a category FDA category 2 agent. So better to use eplerenone rather than spironolactone. But then there are reports where they have used spironolactone without deleterious effects. In fact, there are some anecdotal reports, case reports are there where they used it and they found healthy child was born, including a male child also. So there are, but then better to use eplerenone, which does not have these effects.
Right. Dr. Shomita Mondon. So maybe we go back to Dr. Nihal. How to confirm primary hyperaldosteronism in a patient with reduced GFR? Okay.
Yeah.
With reduced GFR.
Yeah, that's a good question. Essentially, in patients who have reduced GFR per se, I think one should look at the clinical algorithm per se. If the patient is not on a diuretic and has hypokalemia with hypertension with a reduced GFR, say around 30, and the potassium is, say, something like 3 or 2.9, and the patient is not on a diuretic, one should certainly consider this as a possibility. The other possibility, of course, is patients who have a concomitant renal tubular dysfunction or renal tubular acidosis, but they would in fact have bicarbonate levels which are much lower. So take into account the clinical scenario, patient not on diuretics. In this situation, if you do have hypokalemia, do consider a possibility of Con syndrome, we always think of cons as a milder form of secondary hypertension than FIO, but that's not always the case. So you can have significant end organ damage in these patients as well. Patients with renal damage usually will have a hyperreninemic hyperaldosteronism. So renin will not be suppressed. So when you have hyperaldosteronism in the presence of mild renal failure, with a suppressed renin level, you should certainly think about hyperaldosteronism per se as the cause of hypertension. So there's no overlap. If you have a dominant tumor or even idiopathic hyperaldosteronism, you have elevated aldosterone and suppressed renin. So the two kind of don't go together, and it's actually not too difficult to discern between a reduced GFR patient who has no hyperaldosteronism in that situation.
For Dr. Bantwal, and maybe this will be the last question for this evening. This is about interpretation of urinary epinephrine levels. Now, again, in a person who has got renal impairment may be secondary to the hypertension being not properly treated for long. So, how do you interpret those values?
Well, at the time, actually, it is sometimes very difficult to interpret. I think plasma metanephrines could be, if you get a clear-cut four-fold elevation, yes, we are sure that we are dealing with this. Otherwise, in these type of conditions, if the patient is having symptoms, the paroxysmal spells and all, and when there is a difficulty, I think the imaging trumps biochemical diagnosis. So when, suppose the patient is in ICU, once again, the catecholamine levels itself may be a little bit high because of the stress of that. So these are some indications where imaging trumps biochemical diagnosis. So I think whenever you get a symptom, it is said that a rule of thumb is the size of the tumor is approximately 4 to 4.5 centimeters, and we can pick it up easily. If you find only borderline elevation 1.5 times, you don't have it, and you don't get it in the imaging also. So that's a usual rule of thumb. I think Nihal could answer more on that.
Ganapati, you'd like me to comment? I think you put it beautifully. If you have a tumor, you go for the big apple. You do the imaging. You may have even a proportion of patients who do not have any catecholamine elevation, but if it's severe hypertension and you have not found a cause, it may be well worthwhile doing a CT abdomen, which in today's practice is quite easily doable.
Right. So I think we had excellent two presentations, and I hope that both of them have provided enough of interesting cases to deal with the concept of hormone-induced hypertension or endocrine hypertension. There would be other situations that Dr. Thomas has also referred to, for example, in hypothyroidism, in hyperthyroidism. There could be some amount of, for hypothyroidism, maybe there's some amount of diastolic hypertension. In hyperthyroidism, there's more of systolic hypertension. But then hypertension doesn't dominate the clinical picture, so it's something else. But these are conditions where hypertension dominates the clinical picture, and where you could provide a cure for the hypertension by diagnosing this condition. Even if it's not a surgical cure, a specific medical treatment addressing maybe the mineralocorticoid excess could definitely do well in terms of reducing the long-term morbidity related to hypertension. But of course, we also finally need to remember that it's important that about hypertension, the rule of 50 that we commonly say, that only about 50% of hypertensives are ever diagnosed, and of them only about 50% are properly treated, and of those who are treated probably only about 50% reach their targets. So measuring our blood pressure in our patients is so very important, and then offering them the right treatment. And in this context, maybe endocrinology does have a role to play, and of course, not stressing the fact that I think much of so-called essential hypertension also does have subtle hormonal changes as the basis for essential hypertension. So very sincere thanks once again to Professor Nihal Thomas and Professor Ganapati Bantwal for making us wiser, and to all of our audience who tuned in, and I'm told more than 1,000 of you actually tuned in on this 15th of August evening, and I hope it has been of some use to you. It's back to the organizers, and thanks to Intus for providing us this platform.
Thank you, sir.
Thank you.
I, on behalf of Intas Pharmaceuticals Limited, today would like to offer a vote of thanks. Uh, I would first of all like to, offer greetings for Independence Day today. Uh, Today, first of all, I would like to thank all the delegates who tuned in today and joined today for this academic feast delivered by the eminent faculties. I must thank Professor Shobhankar Chaudhary for guiding us in this program and help us organizing this practice pulse in endocrinology. I would like to thank Professor Nihal Thomas and Professor Ganpati Banpal for agreeing to be part of Practice Pulse in Endocrinology and delivering their mastery lectures today. As you know, Practice Pulse in Endocrinology is a monthly program which focuses upon endocrinology for physicians. And this program is being organized on third Saturday of every month by TGLIP team. And please do join us for our next program on 19th of September. And till then, we say goodbye to you. And soon we will be providing you the details of the topics which we will be having for the next program. So thank you very much once again to one and all. And kindly support us for TGLIP and TGLIP-M. So thank you very much once again. Thank you,
Thank
sirs,
you.
and we are really grateful for your lectures today. So thank you.
Thank
Thank
you.
you. Very
Thank you.
good night.
Goodbye.
Stay safe.
Thank you, sir. Good night.
Good night. Good night.
Good night.